Female athlete triad. Karen, it's all yours.
Thank you for inviting me.
My pleasure.
Thank you for being here. How many of you have heard about the female athlete triad? So were you actually at that training all those years ago?
I was not, but I wish I was.
It's showing your age. This was a long time ago. It was back in 2001. This was a program that we rolled out. It was the New York State Public High School Athletic Association Awareness and Recognition Program of the Female Athlete Triad. And the truth is, it was the first of its kind in the nation. Nobody was talking about the Triad back in 2001. So I'm happy to hear that so many of you folks have heard about it. How are you using it? Where have you heard about it? Just real quickly.
I actually heard about it when I was an athlete at Shaker, and one of the Meet the Coaches nights. I don't know if you were there.
One of the Meet the Coaches nights.
Yeah,
That's
one
exactly
of the Meet the
what we
Coaches
wanted.
nights. It was an hour presentation for all the parents and the athletes.
On the Triad?
I don't know what year it was,
Wow.
but that's where I first heard of it. Like, I had to be maybe a sophomore.
Wait, Shaker in Albany?
Yeah, and yeah.
Was that me?
Maybe. It could have been late.
That was a long time ago,
You don't
right?
live it? The Shakers in
Late.
Lake.
Yeah,
Whatever. Sorry.
She went to school with my daughter. They're at that age right now.
And hey, to top it off, Angela was a high honor student too.
She was the high honors, yeah. You like
Okay,
that?
that's great. So you heard about it that long ago. Okay. Well, so anybody else want to talk about where they've heard about it or what they're doing with it? Anybody actually doing anything with it in the school setting? That's okay. That's what we're here. That's what we're here. So so we rolled out the program back in 2001, and really the whole topic of the Triad has really dictated my professional path for many years now, and obviously it's a very important topic. And so today we're just going to talk about the Triad and what makes a girl vulnerable. And you'll have to forgive me a little bit because my slides are not going to work. My remote's not working. So what are we going to talk about? We're going to talk about what is the Female Athlete Triad, how do our girls end up with the Triad, and then what can we collectively do about the Triad? And that's really what I want to spend the most of our time today talking about, because I think we have 3 hours together, right? This is a full day training? It's not? So what is the Female Athlete Triad? Back in 1997, the American College of Sports Medicine, which we all know what ACSM is now, the American College of Sports Medicine came up with this term, the Female Athlete Triad. And let's see if I can get this clicker to work. The Female Athlete Triad. Don't love the name. What's the acronym for the Female Athlete Triad? Not loving that. That wasn't good. Sorry. So that's what they called it. And so 1997 they came out with their first position statement on the Triad. Then in 2007 they updated the Triad, and because we know so much more now about the Triad, about the causes, the treatment, the intervention for it, than they ever did. So what is the Triad? The Triad starts right over here with low energy availability. Please always remember, with or without an eating disorder. So often people think the Triad is only about an eating disorder. And I'm the first to tell you that I am not an eating disorder specialist. It's not what I do. If somebody truly has a clinically diagnosed eating disorder, I refer them out to somebody who has more experience than I do. So you do not have to have an eating disorder to fall victim to the Triad. What is the problem with this low energy availability? It leads to something known as functional hypothalamic amenorrhea, menstrual disturbances, and we're going to talk a lot more about the menstrual disturbances in just a few minutes. What is the big deal about that? It leads to low bone density for chronological age. It leads to osteoporosis. Bone scans have been done on girls in their 20s, and they look like women. I used to say women in their 50s, but now that I'm there, I'm going to say they look like women in their 60s. Because, oh my God, that's so old, right? So that's what happens. Low energy availability leading to menstrual disturbances, leading to osteoporosis. What I like about this diagram, it looks a little complicated, but the bottom line is I was very happy to see that in the 2007 position statement, there's a discussion about how each of these components are on a spectrum. It's not black or white. They're each on a spectrum, and we're going to talk about the spectrum in just a few minutes. So this low energy availability can be very low. It could be reduced energy availability with or without disordered eating. And over here, this optimal energy availability leading to normal menstrual cycles, leading to optimal bone health. This is what we're looking for. This is, of course, what we want. But each of these components are on the spectrum. So an athlete's condition moves along each spectrum at a different rate in one direction or another according to her diet and exercise habits. So she can come in and out of this depending on her exercise and depending on her caloric intake. So she can move along each spectrum.
I'll thank everybody then.
Just recently, just last month, D'Souza came out with a new consensus statement on treatment for the Triad. So in case anybody's interested in that, that's kind of where these colorful, in the past this diagram was black and white, and when I saw the color, I'm like, yes, I love it. Love color. So, the other thing that we have to understand about the female athlete triad, what do you think one of the criticisms that I've been getting for so many years when I talk about the female athlete triad and this low energy availability? Why aren't we talking about the boys? And I'm like, because the boys don't menstruate, in case you didn't know. But what we do know for sure is that boys also struggle with this low energy availability. And so what's about to be released in April, next month from the IOC, the International Olympic Committee, the Medical Commission consensus statement, there's a new term in town. And we've always talked about the low energy availability, but there's a new term that now is referred to relative energy deficiency in sport. And that will now encompass males as well as females. And just to quote them, it's evident that the clinical phenomenon is no longer only a triad. You know, for years we would just talk about not getting enough calories, menstrual disturbances leading to bone health. It's much bigger than that. So we also know that, that in addition to just those components, it's a syndrome that affects many aspects of physiological function, including metabolic rate, menstrual function, bone health, immunity, protein synthesis, cardiovascular events, and of course, psychological health. Okay? So when there's a calorie deficit, the brain and body try to help reestablish energy balance by decreasing resting metabolic rate. I think we already know that. If you're not getting enough calories in, the body says, well, you're not feeding me enough, I've got to, the metabolism slows down. And we have a metabolism expert here who's about to go teach a class in metabolism, so you can teach us a thing or two as well. But thank you. So what happens here? So this is your metabolism, and your metabolism influences all of these things: your immune system, your nervous system, your musculoskeletal system, your excretory system, your cardiovascular system, your respiratory system, your endocrine system, and of course, your reproductive system. So what happens? Your reproductive system burns out. It's the first to go, because the body says, she's not fueling me enough, she's not giving me enough calories, there's no way that this body can support a pregnancy. So it's the reproductive system that's the first to shut down, and it burns out.
They're going to get an email
That's
evaluation.
therefore the flame. Do you like the flame? Tell me that you like the flame, right? Thank you. I was just wondering. Okay. So in addition to all of those other metabolic functions that occur as a result of the decreasing of the metabolic rate, we also see performance consequences, of course. We see excessive fatigue, we see an increase in recovery time. It takes longer to recover and to heal from something. And it could be a broken bone, but it could also be taking longer to get over a cold. Your immune system is compromised. It could be a decreased training response or adaptations. You're training a lot, but you're not seeing the improvements, decreased or impaired performance, and then of course loss of lean body mass. So in addition to the physiological functions, we see performance consequences as well as a result of the low energy availability. So what am I talking about low energy availability? It's such a technical word. The bottom line is that the low energy availability is the beginning of the triad. It all starts there. And what is that? It's defined as the amount of dietary energy remaining after exercise training to support physiological processes. And to illustrate this point a little bit more, let me just explain to you. Okay. So energy balance. So what do we mean by energy balance? It can occur in young adults at an energy expenditure of 45 calories per kilogram of fat-free mass. Okay, blah, blah, blah. What does that mean? Let's take a 135-pound female athlete at a 21% body fat. How many calories do you think that she would need on a training day? 2,500. When you calculate the 45 calories per kilogram of fat-free mass, this girl on a training day needs 2,760 calories. Are our girls getting almost 2,800 calories a day? If you told a girl that, what do you think she would say? No way. That's energy balance. That's where she's not gaining weight, she's not losing weight. The energy balance that Sonia talked about earlier. In exercising women, LH pulsatility, and the LH pulsatility is what leads to the shutdown, is what influences the menstrual cycle. It's what leads to that functional hypothalamic amenorrhea that I talked about before, that LH pulsatility influences the menstrual cycle. In exercising women, that is disrupted below 30 calories per kilogram of fat-free mass. So at 30 calories, what does that mean? That same 135-pound girl, 21% body fat, that's 1,800 calories a day. 1,800 calories. So she's probably getting, maybe she's getting 1,800 calories. So do you think that these menstrual disturbances are pretty rampant? It is. It's out there. The girls are just not eating enough. Study was done just a few months ago, was released in September 2013 by my colleagues at Penn State, and they found that a smaller energy deficit, 35 calories per kilogram of body weight of fat-free mass over time can also lead to these menstrual disturbances. And that equals 2,150 calories for a 135-pound athlete. So you see already how clear it is that the girls are just not eating enough calories. And that's what we mean by low energy availability. And then of course we see with somebody with an eating disorder, the amenorrheic athletes, we see those studies that are telling us 16 calories, and that's less than 1,000 calories a day. That's 980 calories. So does that make sense? Do you have an idea now of what I mean, of what the literature means by that low energy availability leading to that, to the whole cycle of the triad? So the other thing that I think, something that I think is very important to mention is that low energy availability can be intentional or unintentional. It's not always driven by body image issues or stress and anxiety, which I will certainly talk about in just a few minutes. But sometimes girls simply lack the knowledge, the skills, and the resources to fuel themselves adequately. They don't understand about the connection between nutrition and athletic performance. They don't understand about the value of a recovery meal. They don't get why breakfast is so important. I call breakfast the pre-competition meal of the day. And we do need to find a way somehow to eat it, but not forcing a kid to eat when they're not hungry. But they just don't know. And why don't they know? Their coaches, their parents, we can't expect parents to be sports nutritionists, but coaches are not talking about this enough. We have to get coaches to understand, and athletic trainers and health educators, all of us collectively, we need to talk about that influence that nutrition has on athletic as well as academic performance. So that's a whole nother conversation. But they just don't know. So, what are these menstrual disturbances? Let me just define that a little bit more. The menstrual disturbances that we see with this low energy availability are a couple of different ones. One is oligomenorrhea, which is menstrual cycles occur at intervals longer than 35 days. Primary amenorrhea, which is the absence of menstruation by age 15 or within 5 years of breast development. And by the way, this was a change that was made on the position statement, the second position statement. We used to say by age 16, and now we say 15. And perhaps it's girls are menstruating earlier because of the obesity. Would you agree with that? That's probably the obesity. Girls have a lot more body fat. They're menstruating earlier now. So that's an important distinction. And secondary amenorrhea, and this is the one that I see in my practice all the time. Absence of 3 or more consecutive menstrual cycles in a girl who has already begun to menstruate. So by the way, here I am just freely talking about menstruation, and I know some of you men in the room may be cringing a little bit. I hope you're not. But if you are, get over it. Just kidding. No, I'm just kidding.
Yeah, John.
You don't have to get over it. Are you dying back there? Really? Did I know I was going to? Did I have to stay for the session after lunch? Really?
Quick question. Percent of body fat.
Percent of body fat is not a factor in this.
Is that something that was an old thing they used to say?
It is an old way of thinking. There used to be a time, I remember when I was in graduate school, and I was begun to think about all this. I had done a lot of work with wrestlers, and I was always interested in weight management, and not that, wrestlers have this same issue, but, and I remember hearing, oh, you have to have a 22% body fat. It's absolutely not true. So the scale is not a factor in this necessarily, and your body fat is not a factor in this. So that's an excellent, excellent question. I'm glad you brought that up. Not that percentage of body fat is not important, but not as it relates to this. That's an excellent question. And I can also remember, even my pediatrician, I have a 21-year-old daughter, a 20-year-old son, and she would say, oh, well, you have to be, your daughter has to be, 110 pounds. I'm like, what? That's just not true. But I kind of taught her, that what she was saying was not accurate. Okay, so how does all this influence bone health? So why do we need to be concerned? Females gain more than 50% of their skeletal mass during adolescence and reach peak bone mass between 18 and 25 years of age. So, and we know that with the absence of menstruation, with these menstrual disturbances, it leads to the onset of weakened bones. It's the whole endocrine system, the decrease in estrogen, as well as a lot of other hormones that are involved. I don't want to bore you with that. I have another slide that I can bore you with it, but I thought for our purposes today, because I realize I'm used to doing this in an hour and we only have 45 minutes. So the bottom line is that that low energy availability, the menstrual disturbances, it sets the whole endocrine system off on a pattern, in a frenzy, and all of that influences bone health. Yes?
Can any of this be regulated with birth control?
Oh, well, there's always somebody that's got to ask that question. And that usually I wait till the very end. I'm going to answer that now, and then we could talk a little bit more about this afterwards. But people will, that's just putting a Band-Aid on the problem. And so when we put a young girl on the pill who's irregular, who hasn't gotten her period, and she hasn't had her period for 6 months, we put her on the pill, what's going to happen when she goes on the pill? Her period, she'll become regular. Will she put on a little bit of weight, perhaps? Will that just compound the problem? Are we just masking the issue? And then the other thing that we know is that many of the pills really, they may bring on menses, but they're really not doing much to strengthen bones. And that's a whole nother conversation, but it's an excellent question. Okay. So at the very time in these young girls' lives when they're supposed to be building up their bone stores that will carry them through the rest of their life, with the onset of these menstrual disturbances, they're now losing bone when they should be building up. And if we also know that only 10% of adolescent girls are meeting the recommended daily allowance for calcium in their diets, we know that we have a real problem on our hands here. We have a real issue for their bone health. Bone density declines in proportion to the number of menstrual cycles that are missed. Among those high school athletes with menstrual disturbances, musculoskeletal injury was 63%. They were 3 times more likely to sustain an injury resulting in 7 or more days lost sport time. That's a big deal. This is something that we need to sit up and take notice. So right away, if we have an athlete that is dealing with injuries often, is a red flag. It's time to say, so, you getting your period? As comfortably as we can. And I was teasing before that some of you men who may not be comfortable talking about this, and maybe, none of us, man or woman, may not be comfortable. If you're not comfortable, then you need to find somebody who is. And you need to make sure that at a preseason meeting, and you were lucky enough that you sat through an hour session of this, preseason meeting, we need to talk about this. We need to understand that amenorrhea is not a normal consequence of athletic training. Because how many girls are saying, oh, of course I don't get my period. I'm such an athlete. I train so hard. And it's been very difficult. I mean, that is the mindset since the 70s. And it's very difficult to get that mindset out of the normal mainstream thinking. But it is a red flag that there's something going on. Now, again, I don't want to create a problem where there isn't, but ask questions. Ask questions. And we'll talk a little bit more about a pre-participation questionnaire in a little bit. And then the last point is low bone mineral density may be irreversible, resulting in a lifetime of lower bone density. So this is something that we need to take very seriously. So who's affected? So what's the big deal? Up to 70, I could go on, I could have 3 slides of statistics, and to be honest with you, I do, but I hid them. So I don't want to bore you with too many statistics, but I feel that we do need to have some idea. Up to 78% of high school varsity female athletes are found to have 1 or more components of the triad, either not getting enough calories, menstrual disturbances, or low bone density for chronological age. Up to 66% of female athletes are experiencing amenorrhea. Personally, I think that that's low. I mean, obviously, I have a private practice on Long Island, and I do see a lot of athletes, and it's just so common. It's just so common, and they're like, well, I don't get my period, and of course they're happy. You know, why talk about it? You know, they're happy. It's a relief, right? Girls aged 11 to 17 who participated in more than 16 hours per week of activity had a higher incidence of disordered eating and stress fractures than their peers. Take note of the word disordered eating. We're going to talk a lot more about that in just a few minutes. Take note of the fact that I didn't say eating disorder. Okay, we'll talk more about that. Low bone mineral density was seen in 38% of adolescent athletes with amenorrhea. I think that that's low. 45% of adolescent athletes are disordered eating. Again, that's all. I'm giving you the research, the statistics here, but disordered eating, when we talk about disordered eating, you're going to realize that we're all disordered eaters to some extent. But, you know, teenage girls often start to diet to avoid weight gain. And so therein begins that's the beginning of that low energy availability. And thank you, Sonia, for talking about it. I'm sorry?
They start to small.
Yes. Oh, yes. Oh, I'm talking too fast. I'm thinking that I don't want to lose you because it's after lunch and you're probably already thinking of what you're doing after when you leave here. So taking a meditative moment. Yeah, so I was happy that you talked about that your program was not about getting girls to diet. Girls who diet in the early teen years are 3 times more likely to become overweight 5 years later, and I think a lot of people don't realize this. And there's a lot of data on the fact that dieting makes you gain weight, eating keeps you lean, and I think that you know that was discussed a little bit earlier. That eating will help keep you lean and healthy, but dieting will lead to weight gain. How many of you have ever been on a diet? How did you feel when you were on a diet?
Terrible.
Deprived. And then what did you do when you went off of your diet? Ate more. Exactly. So we could go on and on about that. 81%, this is something that is so unsettling to me. 81% of 10-year-old girls are afraid of becoming fat. I think we could talk about body image a lot. I will talk about that later. Okay. I think I had some more stats up there. But the other thing to keep in mind is that one does not need to be an athlete to fall victim to the female athlete triad. You just need to be somebody who's running around, is very busy perhaps a little concerned about their body weight, a little bit concerned about their body image, and are just obsessed about appearance. And I think that that's what our society leads us to. So you certainly do not have to be an athlete. Again, another reason why I don't love the term female athlete triad. It did kickstart a lot of work that I do, but I think that we have to understand when we talk about the female athlete triad, it's not just the athlete that falls victim to this. Critical concept. Now this is a very important point because I know, again, as I mentioned, in 1997 when the first position statement came out from ACSM, there was a lot of pushback about the term the female athlete triad because people were saying, oh, are you suggesting that our girls, that they shouldn't be athletic? Are you saying that they're too weak because they can end up with these bone problems? And of course, that's not what anybody was ever saying. Nobody has, the research does not tell us, and nobody's ever saying that exercise is the cause. Exercise in and of itself does not induce amenorrhea. It's the fact that exercise may contribute to sustained low energy availability in the presence of inadequate dietary and nutritional intake. So while you don't have to be an athlete, as I'm saying, if you are somebody that's a little bit more physically active, you may be, you may be at risk if you're not consuming the calories that are required. And when I went through all those calories, you see that, before you know it, you do need those calories. So it adds up. So the impact of stress. Stress associated with performance, relationships, and family dynamics can drive body dissatisfaction and dieting behavior by contributing to the overall perception of self-worth in girls. And I think that it's very important that we understand the role that stress can have and how our girls all of us are leading very complicated lives, and the more complicated our life is, the more stressful it can become. But that body dissatisfaction and the dieting, those are the gateway behaviors and gateway attitudes that leads to that low energy availability and not taking enough calories in. So all of that influences how a girl feels about herself. And so begins the vicious cycle. You feel bad about your body, you either overeat or undereat, right? Sometimes we overeat when we're feeling bad about ourselves. If we feel bad about our body, we're less likely to take care of our body. We know that body dissatisfaction will actually lead to weight gain. And as important as the whole childhood obesity discussion is, and I know obviously that was not addressed here today, but there are people that think that if we just make people feel bad about themselves, then that will inspire them to want to lose weight. And we know that that is absolutely not the case at all. The better you feel about your body, the more likely you are to take care of your body and nurture your body. So the worse you feel, the more likely you are to diet, the more likely, and then of course the vicious cycle starts. Depression and anxiety can either precede, follow, or coexist along with the disordered eating behaviors. Right size, wrong size attitude can lead to a loss of self-worth. And so these kids, when we talk about weight loss, and if we're telling these kids that they are not the right size, that can lead to them to feel even worse about themselves. And it's not that we're not encouraging them to become healthier, but if we're encouraging them to lose weight, that's only going to perpetuate them to feel worse about themselves, rather than do something inspiring to get them to take a proactive approach to eat healthier and become more physically active. The more complicated life is, the more stressful. You must learn to decrease the emotional reactivity. I added that bullet point last night, actually. I was at a conference on Monday about yoga and mindfulness within the school setting. And there's so much research coming out now. We're on the cusp of all this, right? You're nodding. Are you a yogi? Yeah. And we've got, I know, you're a yoga instructor, and so we know that there's this is something that we really need to offer more in the schools. To me, along with all that we're talking about, eating more fruits and vegetables, becoming more physically active, we also need kids to do more yoga, be more mindful. Do some meditation, focus your mind. There's just great research to support the benefits of that within the school setting. Individuals who accept their own unique shape have self-compassion, which is correlated with an increased resilience to stress, as well as improved self-care. Back in the 90s, everybody was talking about self-esteem. That's how far back I go since I've been doing this. But now I think it's more self-compassion, that non-judgmental, accepting yourself. And nurturing yourself. Not accepting yourself if you're not in a healthy way, but just being more non-judgmental, not being so hard on yourself. So I probably should have put this slide before. So what I like to always talk about, and I had said this when we first started, about the eating disorders being on this end of that spectrum. The reality is, there's a great book out, this is where I got the statistics from, called Almost Anorexia, by Jenny Thomas and Jenny Schaefer are the authors. And I love that name, Almost Anorexia, because you don't quite have that clinical diagnosis, but you're almost there. And we know that full-blown eating disorder, this should be reversed. It's 1 in 200 have a full-blown eating disorder, this is correct. Whereas the disordered eating in the middle is much, much more common. Over here we have healthy eating on this end of the spectrum, and this is where we want the girls to be, just like we saw in that very first slide. Disordered eating has become the norm. Many girls are flying under the radar. And if they don't have that clinical diagnosis of anorexia, of bulimia, and by the way, this eating disorder has become much broader. In June of 2013, The criteria for clinical diagnosis of an eating disorder broadened. It now includes binge eating disorder in there. So when we look at the whole issue of obesity, we have to look at binge eating. Clearly, that's a factor. So, but this is a clinical diagnosis. This is not a clinical diagnosis, but it is much, much more common. And so girls will come in and out of those disordered eating patterns. And so this is what drives my work for the last 20 years. This, I mean, I would never be so bold as to say that this is easy to manage within the school setting, but if you know that somebody has been diagnosed, you kind of have some idea of what to do. There's no roadmap for this. What do we do about this disordered eating? The best that we can do is hope that we can educate, teach, inspire, motivate girls and boys to understand disordered eating. It's become a rite of passage. Girls will think that they're cool by grabbing a cup of coffee for breakfast, eating a green salad for lunch, skipping dinner, and then going to practice, right? I mean, that has become the norm. When I was little, it was cool to walk around in your mom's high heels. Now it's cool to look like, I'm going on a diet. That makes you feel older, it makes you feel more sophisticated to say that you're going on a diet. I'm cutting my calories down. I'm too fat. So this disordered eating has become the cultural norm, and it worries me that many fly under the radar, and they live a life like this. And this disordered eating is very often accompanied by a lot of angst, a lot of, obviously poor nutrition, poor athletic performance, poor academic performance, but a lot of emotional angst is associated with this disordered eating. And people live a life that way. So the definition, if you look at the position statement, various abnormal eating behaviors including restrictive eating, fasting, frequently skipped meals, diet pills, laxatives, diuretics, enemas, overeating, binge eating, and then purging. So it's kind of like dabbling in those eating behaviors. You don't do it enough to meet the clinical criteria, but you're dabbling with that a little bit. So what are the triggers for disordered eating patterns? How do these girls end up there? Nobody here, of course, but sometimes girls feel pressure from coaches, parents, and peers to be thin. It's just the society in which we live in. A girl may not be a great athlete. She looks at the star athlete on the soccer team. That girl's super skinny. Oh, I want to be like her. If I was skinny like her, I'd be a better athlete. So we feel pressure to be thin. Not to be healthy, but we feel pressure to be thin. Traumatic experience with weigh-ins or comments from a coach or teammates. I would almost add traumatic experience with sometimes the conversation of BMI. And that's a whole nother discussion, and obviously BMI is an important number, we need to have an understanding of it, but just as we have to be mindful, like these days, you probably would never dream of weighing kids in a group all together, right? Well, we have to also be careful about not perhaps throwing out a BMI and say, oh, your BMI is this and your BMI is that. Even when we send that information home to parents, I think that it needs to be accompanied with important information, because that concerned parent will get that information and say, oh my God, my child's fat, I've got to put my child on a diet. And we have to understand we're not, this is not about weight loss, this is about seeking health, not weight loss. Oh, necessarily, I should qualify it, not necessarily. The onset of puberty, a classic example, I had a dad call me. He has a 4th grade daughter who's a swimmer, and in my town where we live, it's a big swim team, big club swimming, and he called me up and he said, my daughter's in 4th grade and she's gotten a really fat stomach. First of all, he said to me, she's gotten really fat and I don't want her to end up like my wife. So I'm like, do I really want to take this client on? Yeah. And then I thought, I better. Yeah. So in the meantime, she's in 4th grade. He's got to understand the stages of maturation and what her little body is going through. But if you don't understand this, and all of a sudden, oh my gosh, that little bit of abdominal body fat that before your body gets ready for menstruation, it's normal. Negative self-talk about athletic achievement. Again, if I were skinnier, if I weighed less, I would be a better athlete. Fat talk. This is, and I'll tell you about this. I'll mention it now. I'll show it to you later. Fantastic research work by a woman named Carolyn Becker out of Trinity University, and she has a program called the Body Project, and it's four 1-hour sessions to be done on a high school level, and it's all about resisting the thin ideal, and it's all about resisting fat talk. What is fat talk? Oh, my thigh, I look so fat in these jeans. Crop my arm out of my picture, it's so fat. You know, all the things that we talk about. I have a handout that we have in our first program that we developed with the Athletic Association, 5 things you should never say in front of your daughter. You know, like, do I look fat in these jeans? And so that fat talk is very negative, and it's very, very dangerous. And it perpetuates the whole problem. Girls will be sitting around in the locker room saying, oh, I'm not wearing those spandex. Oh, it just shows up all my cellulite. Oh my God, how could that girl think that she can get away with wearing those jeans? You see that muffin top? You know, that is fat talk. How common is that? How many of you, show of hands, is that common? Do you hear it? Girls talk that way all the time. As parents, you know, anyway, all right, I'll reel myself back in. But yeah, we have to be very mindful of this fat talk, because it's certainly a trigger for disordered eating. The competitive thinness, and we see this so often. Girls, you know, are, you know, all getting together and like, who's thinner? Who's ever thinner that's the one that gets the badge of honor. Who's ever the thinnest. Low self-esteem, obviously feeling poorly about yourself. Trouble handling stress. I mean, obviously, the inability to manage stress, the inability to manage your emotions. And that's, to me, another reason why meditation, mindfulness, yoga, that is wonderful. We know from research the benefits of meditation and how that really helps decrease that emotional reactivity. But obviously, you know, girls, in order to manage their stress, that, well, if I just looked better, or if I was thinner, I would be better at this. Trouble managing emotions. This cultural obsession that we're talking about, and dieting at an early age. So these are all risk factors. These are all triggers for the onset of those disordered eating patterns. I just wanted to say just one slide about eating disorders, and I wanted to bring this to your attention because I think it's important that you could be coaching, you know, your lacrosse player, and she's the best one on your team, and she's always the one eager to please, always the one willing to do above and beyond, always the one willing to be the best. And that may be great, but just look closely, because when we look at the good athlete, that's the one that's, you know, mental toughness. The anorexic one is that self-denial, the asceticism, denial of, you know, of any pleasure. I'm going to do what I have to do no matter what. Kind of like the monks in the beginning, right? So that you know, that's a good example of the asceticism, and that's just not healthy for most of us. Commitment to training. We want our athletes to be committed, but they are excessively exercising, and they end up with overtraining. And so they really, after a 2-hour grueling practice, that same athlete goes out and runs another 5 miles just because she wants to be better. She wants to prove that she can be the best. The pursuit of excellence, of course you want our athletes to be the best they can be, but they will stop at nothing less than perfectionism. Coachability, that's great, but really the one that's so eager to please and really being over-compliant. Unselfishness, that's a great quality, but selflessness, that they just are willing to give up the essence of themselves. Perform despite the pain, you know, toughen up, right? But this is denial of discomfort. Well, I'm going to run through my broken ankle. You know? So that is, there are similarities, and you know, in the world of athletics, you know, we encourage these qualities, right? These are the things that we want to see a little bit, but we have to understand that there is that fine line, and we have to perhaps, you know, step back a little bit and say, am I encouraging this? Am I, you know, what am I doing to contribute to this behavior that may ultimately be very dangerous? So, when you know better, you do better, right? So we've talked about all of this. We've talked about a little bit of what the Triad is, some of the triggers for it, some of the pressures that girls feel. Any comments or questions at this point before I go on? Okay. So when you know better, you do better. So what can we do? First thing that we can do is we certainly don't want our little girls getting on the scale saying, oh my, you know, what do I do about this? We don't want them to start worrying about that scale very early in life. Don't step on it, it makes you cry. Right? How many of you have felt that way? Come on. True, right? So if dieting is not the answer, if getting on the scale is not the answer, what is the answer? And by the way, I don't need to be so bold as to think that I have all the answers. I think collectively we can work on coming up with these answers. But I think that we need to create a new language around food and eating and of becoming healthier. There's a multitude of research that shows that developing self-compassion actually increases the likelihood of improved health. And I just feel that if we can lead with health rather than leading with weight loss, we're setting ourselves, our boys and our girls up for a lifetime of good health. So the key here is not weight loss, the key is health. And I think that all of our speakers, all the speakers today have talked about that. Because coaches will always say, yeah, but I have a girl, she's put on a lot of weight, she came back from the summer, and like you talked about the summer weight gain, she came back from the summer and she's really slow and lethargic, and she's absolutely put on a lot of weight. And I'm not for a moment suggesting that weight gain in an excessive amounts, that overweight and obesity is healthy. Don't misunderstand my point, I'm not saying that at all. But if that coach says to that girl, lose 5 pounds and you'll run faster, is he helping or hurting her? But if he says to her, let's focus on strength, quality nutrition, mindful eating, physical conditioning, the mental and emotional components of performance, weight loss, if necessary, will follow. So if that coach is spending time talking about the role that nutrition has on athletic performance, and if we're focusing on the skills and the drills and the techniques that are required to improve your performance in that given sport, if you're focusing on the quality carbohydrates, the quality protein, you're getting away from those sugary drinks, and you're focusing on quality nutrition, then weight loss, if necessary, will follow. The problem becomes when we try to make that little girl look like something she was never meant to be. Maybe she was 13 and now she's 14 and she's getting a little bit more womanly and she is getting more hips and she is laying down some body fat. Maybe that was what she needs to do. If it's interfering with her performance, if it's interfering with her health, that's another conversation. But if we lead with health, then weight loss, if necessary, will simply follow. It's just that when we lead with weight loss, that's when we get into trouble. So, okay, this is intuitive eating. I could spend 3 hours just talking about this. I have a great handout that Elise Resch, Elise Resch and Evelyn Tribole wrote the original book on intuitive eating. They coined the term. How many of you have heard the term intuitive eating? Oh, is that a new term for you? Oh, you've heard it. Some of you have heard it. Okay. Well, intuitive eating is really simple. It's relying on your physical hunger and satiety guides to guide eating. Imagine that. Imagine eating when you're hungry and stopping when you're full. Who knew that that would be a good thing to do? How many of us really do that? We've gotten so caught up, and I know any of you young moms, and you probably, I'm sure you already know, but my children were brought up on the whole philosophy of Ellen Satter. Anybody have ever heard of Ellen Satter's work? She's written great books about intuitive eating and feeding young children. She's written, eating with good love, helping with that, harming, eating with love and good sense. She's got some fantastic books. But it's intuitive eating is something that we should automatically be doing. But as a society, we've completely gotten away from this. And we know that just at an Appetite of 2013, a year ago, girls who reported that they stopped eating when they were full had lower odds of dieting and binge eating than those who did not stop eating when they were full. And to me, like, what? Duh! Isn't that like, are you kidding me? We needed research to tell us that, but apparently we did. But this intuitive eating, in order to become an intuitive eater, we really need to be more mindful. And I was happy that just a couple of months ago that mindfulness is becoming a bigger part of mainstream media. This was on the cover of Time magazine. So we need to slow down. We need to be more mindful. There was a lot of talk this morning, and I agree so much that there are many ways to eat healthy. What works for you may not work for me, and so we need to know our individual risk factors, our individual lifestyle. There are many ways of eating healthy. So as a nutritionist at this stage of my career, I'm much more interested in how and why somebody is eating than what they're actually eating. Because it's important, but it's much easier to talk about what you should be eating than the how and the why we are eating. So I think that that's something that we really need to do. I'd love to see in health education classes offer more about have teachers talk about developing a healthy relationship with food rather than just teaching them how to read a food label or rather than teaching them how many, how to count calories. That's nothing as compared to the how and the why. So other things that we need to do. Great research from Newmark Steiner out of the University of Minnesota. I've got, again, I must have umpteen slides about her research, but the bottom line is I think that what we all need to do, and I think that this is really what pulls in the obesity discussion and the eating disorder discussion, is the identification of the risk factors that are shared between weight-related disorders as an essential step to developing effective prevention interventions. And what we know for sure that these are the shared risk factors between obesity and eating disorders. Dieting, you will either gain weight or lose weight. And it's crazy because, we are either in control, restricting our eating, not getting enough calories, or we are out of control, overeating, binging, and eating too much. And the hope is that we will find a way to be more in charge, and that's more where that mindful eating comes in. So this dieting certainly leads to weight gain, and it certainly is the gateway behavior into eating disorders. Media use, we talked a little bit about that a little bit before. You talked about marketing, but I love the way you talked about harnessing the power of marketing in a positive way. But I think that we really need, and I think a lot of health education classrooms are doing a great job talking about body image in the media. This body image dissatisfaction, making kids feel bad about their bodies is not a solution to getting them to lose that weight. And then, of course, weight-related teasing is another shared risk factor for the onset of an eating disorder, as it is for, and understanding that you can have anorexia and binge eating at the same time. They can coexist, and I don't think a lot of people realize that. So what else can we do? Okay. I have a lot to say here. Okay. Know your community resources. Learn how to refer and to whom. And one thing I always, anytime I'm working with the school district about the Triad, the first thing that I say to them is meeting number one, or before we even sit down and meet, figure out who are the resources in your community that you can refer to if you are concerned about an athlete. Know who the sports nutritionists are in your community. Know who the clinical psychologists are in your community. It's great if they are certified in eating disorders. That's always very helpful, because just like a dietitian may not be an expert in sports nutrition, a psychologist may really not know about an eating disorder. But really, you must know who your community resources are and know how to refer and to whom. I also have a very good handout. I didn't bring it with me today, but I can send it to you if you want, on how to talk to an athlete when you're concerned. Somebody that helped write this is a professor from Manhattanville College down in Westchester, and she talks about, just like with suicide prevention, if you see something, say something. And she's done a lot of work with girls, athletes who are recovered athletes from an eating disorder. And unanimously, what her research tells us is that all the girls said, how did my coach not say something to me? Didn't my coach know that I was having a problem? How could my coach have ignored me? And the problem is, it's not that the coach intentionally ignored, it's just that sometimes we don't know what to say, and we don't know how to say it. One of the next projects that I'm going to be working on is putting together a little short video of role modeling a male coach talking to a female athlete. Is that something that you would find helpful, you think? Did you want to ask a question?
Well, just that's very helpful. How do you talk to the female women?
Yeah, it's very
You kind of
difficult.
watch what you say and how you say it.
You do, and I have to tell you, you do have to watch what you say and how you say it, and there is an art to it, because you don't want to do more harm than good, and I respect the fact that you get that. But that doesn't mean, I don't want you to be frightened by it, you just need to be educated a little bit more. And so give me your email and I'll make sure that you get this one handout. But again, I'm not assuming that you're going to learn everything that you know from a handout, so that's why we're going to be putting together a little short video on that.
I do think very few male high school coaches would feel at all comfortable asking their female athletes if they're getting their period.
I agree with you, and that's why, right, there's no way, but they don't have to ask. I'm not, thank you for bringing that up, because there's no way that I'm suggesting that a male athlete says, so, you get your period this month? That's not what he has to say at all. It's more like, how are you doing?
Right.
How are you feeling? What's going on? You know, I've noticed that you've been a little bit quieter at practice these days. You know, I noticed that you haven't been eating with the team lately. You notice the things that you notice, not the things that you don't notice. And you certainly don't notice that that girl's not getting her period. So you talk about what you see, not what you suspect, right? So I think that's a really good point. I'm glad that you brought that up. Educate your community and parents, have preseason meetings. I have a handout. I didn't give it out before. It's just a handout on what is the Female Athlete Triad Talks. I also have another handout. Again, I can send it to you if you want. And it's just 5 questions or 5 or 6 questions. You should be concerned with your daughter if she's missed her period for the second month. She hasn't gotten her period, you know, by the time she's 15. So it's a very good handout that I really suggest that schools give out at preseason meetings. But you've got to educate your community. You've got to get them to understand that amenorrhea is not a normal consequence of athletic training. Offer an appropriate pre-participation questionnaire. Collaborate with your school nurse, your school physician. When we did this program, when we rolled out the program in 2001 with the Athletic Association, we had a beautiful manual. Does anybody still have that manual? If you attended the training, you might still have that big fat manual. We gave out we developed a video, and we had actually 2 videos, one from ACSM for school nurses and school physicians, and then we had another video that could be used in a classroom. And there was a pre-participation questionnaire in there, but we made a mistake, and I'd like to talk to you about the things that we did wrong. We gave out a pre-participation questionnaire, and we asked questions about girls' menstrual cycles before we educated the community. And so, and we did a pilot test. We had 3 pilot school districts on Long Island before we rolled out the whole program. And one of, you know, in one of our communities, how dare you ask questions about my daughter's periods? It's none of your business. And they were absolutely right. We made a huge mistake. We forgot to tell them why we were asking the questions. So don't make the mistake that we did. Learn from my mistakes. But I really encourage you to ask, to develop a pre-participation questionnaire. I probably have a slide on it, but I'm going to skip through that one. But if you want some specific questions, there actually have been some, actually a study that just came out, came across my desk this week, something that was proven to be effective in looking at the female athlete triad, so I can give you that research. Create a safe and trusting environment where students can share feelings, thoughts, and concerns as best as possible. De-emphasize weight. The thinner student is not always more competitive or healthier. Thin does not mean healthy, nor does it imply, nor does large imply unhealthy. Eliminate competitive thinness. Treat each athlete as an individual. Discourage overtraining, and also understand the signs and symptoms of overtraining. Know what that looks like. And if you don't know, look it up. Understand the maturation process, we talked about that. Educate about stress management, decision making, goal setting, problem solving, coping skills. Get into some yoga and mindfulness and meditation. It's very, very powerful. Teach about nutrition, dieting, and the connection to health and performance, and teach about how to develop a healthy relationship with food. I started to say before that Elise Resch, along with Evelyn Tribbley, who coined the term intuitive eating, wrote their whole book, and it's like a little 6-page handout that she wrote for a program, this Think Eat Play program that I consult for. So if you want that, it's a great little piece that I think you could do a great lesson in the classroom with. So again, email me and I'll send that to you. Talk about mindful and intuitive eating. To me, this is such a solution to so many of the issues that we have, I personally think, with obesity. Pay attention to your own comments and behavior about size and shape. Eliminate derogatory comments or behaviors about weight-in, no matter how subtle, light, or in good fun they seem. Don't tease. Don't tease. Oh, you're getting a little pudgy. That's not cute. Even the slightest comment suggesting that weight is too high can motivate someone to engage in unhealthy dieting behaviors. Things like, oh, you look great. Did you lose weight? Keep up the good work. If you lose 5 pounds, you'll run faster. Keep up the good work. That means keep on losing weight. Maybe a little bit of weight loss is healthy and warranted, but if you say keep up the good work, well, I got a lot of attention from my coach because I've just lost 5 pounds. Maybe if I keep on going, I'll get even more attention. Maybe I'll get more playing time. And again, that could lead somebody down the slippery slope of good health. Performance should never come at the expense of health. Banish that talk. We talked about it. I'm going to skip that one. Some effective body image programs, I have them here. Two that I like the most, the Carolyn Becker one that I was telling you about, Resisting the Thin Ideal. Carolyn Becker found that there was an increase in students spontaneously seeking medical consultation for the female triad, but she also found that there was a reduction in this thin ideal that so many people have internalized. You know, being thin is the best way to be. And that's for the high school setting. Kathy Cater's program, I've taught this curriculum myself many, many times. I've trained schools on the use of this healthy body image curriculum, and that's geared for grades 4 through 6. I have them both on me if you want to take a look at them. They're two evidence-based programs that I think are outstanding. So in summary, what is healthy eating anyway? Is it having grandma nurture you with a nice nice bread, you know, home-baked bread? Is it eating, all the food groups? Is it only eating fruits and vegetables? Is it eliminating any of the cakes and cupcakes within the school setting? Is it sitting around a meal? And I would argue for all of that, but I think it's more than that. I think the bottom line is that healthy eating is being able to eat when you're hungry and to continue eating until you're satisfied. It's being able to choose the food you like and eat it and truly get enough of it, not to just stop eating because you think you should. Now, if you learn if you learn to eat when you're hungry and stop when you're full, that will work for you. If you really learn about those internal cues and your own satiety, that will work for you. It's being able to use some moderate constraint in your selection to get the right food, but not being so restrictive that you miss out on pleasurable foods. I loved what you talked about earlier, the 85% and the 15%. And it's giving yourself permission to sometimes eat, sometimes, because you're happy, sad, or bored, or just because it feels good. I think it's important that if you're going to give yourself permission, at least be conscious of it. Be aware that, well, I'm a little frustrated, so I'm gonna eat these whatever it is. But at least you're aware of it. I'm not saying to do it, but at least know it. Don't do it often, but at least know that you're doing that. It's 3 meals a day most of the time, but it could also be choosing to munch along or graze or whatever works for you. This is the part that I love. It's leaving some cookies on the plate because you know you can have some again tomorrow, or, and that's kind of good to do because then they're there for you the next day, or it's eating more now because they taste so wonderful when they're fresh. What's better than a baked cookie? Come on. It's overeating at times, feeling stuffed and uncomfortable. It's undereating at times and wishing you had more. It's trusting your body to make up for your mistakes in eating, and I think that this is such an important point. We've lost that ability to trust ourselves. We don't trust that, okay, so I ate a little bit more today. I'm good. You're going to be okay. You will survive that. But we've lost the ability to trust. We've lost that internal wisdom. We don't teach that. We don't talk about that internal wisdom. It takes up some of your time and attention, but keeps its place as only one important area of your life. Have you ever been to a party with somebody who's on paleo? All they want to talk about is what they're eating and what you shouldn't be eating. It's really boring. So in short, normal eating is flexible and it varies in response to your emotions, your schedule, your hunger, and your proximity to food. So the bottom line is the female athlete triad is not an inevitable consequence of being physically active nor being an athlete. Simply, it's a mandate to educate women and those involved in their training and medical care about the requirement for optimal energy intake, energy balance, and quality.